Thank you for joining me today. My name is William Reisacker, and today we're going to be talking about pharmacotherapy for allergic rhinitis. We're going to be covering all the different classes of medications and how to best target those medications to take care of all the symptoms that our allergic patients are having. So this is information that we've seen before. These are the common symptoms of allergic rhinitis, particularly sneezing, itching, and runny nose. So these are the symptoms we're going to try to target most. Now this is a total symptom score. So this is a combination of the nasal symptoms such as sneezing, itching, rhinorrhea, and congestion, and then combined with non-nasal symptoms such as itching and burning in the eyes, as well as itching in the ears and palate. Now this is the early phase reaction. We talked about isotype or class switching, where antigen-specific IgE is created, and then that IgE binds to mast cells. Well, this is what happens when the allergen then gets back into the system. It cross-links the IgE and binds to them, and this causes the mast cells to degranulate. And this is where preformed mediators like histamine and proteases are released. However, there's also de novo synthesis, so newly generated mediators are synthesized as well, and you can see the list below. And what this causes are some of the prominent symptoms like rhinorrhea, itching, and sneezing, and this is due to the dilation of blood vessels as well as irritations to the nerves. This can occur within minutes of the reaction. So this is the late phase reaction, and this is where we see many of those chemotactic factors are causing recruitment of cells, such as eosinophils, basophils, monocytes, and lymphocytes, and you can see all the mediators that these cells bring to the party as well. And this produces the prominent symptoms of the late phase reaction, such as congestion and rhinorrhea. And while the early phase occurs within minutes, the late phase reaction can occur within hours and last even up to a day. So first let's talk about nasal saline. This is one of the more benign treatments that we recommend for the nose, although it can be very helpful for cleansing out the nose, moisturizing, releasing some of the particles and the allergens that can sit on the nasal membranes, and it can also improve mucociliary function. Now, the way of delivering the nasal saline really depends on the job you're trying to accomplish. So if you're trying to moisturize the front part of the nose, then a nasal saline mist or a nasal saline gel will do the job just fine. If you're looking to get some mucus from the osteomeatal unit region, then certainly a good irrigation is helpful. Neti pot, which you see pictured here, is something that many of our patients are on. I never recommend a neti pot. I'm not a huge fan of it myself. I don't see the point in really pouring the water into the back of the nose and having it come around to the other side. I've also seen where this can cause clogging in the ears, and I just warn my patients that can happen. Certainly, if they're getting a benefit, they can continue. But I wouldn't recommend this if there's a lot of nasal congestion going on, because, again, it can gain access into the osteomeatal unit and kind of get into the sinus passageways, and it can also get into the eustachian tube orifice. Corticosteroids, these are probably one of the most powerful agents that we have for treatment of allergic disease, and this works very well for all the symptoms that we're trying to treat, like sneezing, itching, runny nose, and congestion. And it can be divided up into systemic, either oral or injectable, as well as local or topical corticosteroids. So let's look briefly at the mechanism of action for corticosteroids. These bind to intracellular targets, and it will prevent the allergic cascade really for whatever reason the inflammation is occurring. It's not specific to allergic inflammation. It'll work well with the inflammation caused by a viral illness as well, and downregulate the entire inflammatory response. And you can see here listed some of the specific features of this downregulation. So let's look at the intranasal corticosteroids. This is a class of medication which we are very familiar with and very comfortable using. It's the most effective medication class at controlling all of the symptoms that we're looking to treat in our allergic patients: sneezing, itching, runny nose, and congestion. And right now it is considered the first-line therapy if it's moderate, severe, intermittent rhinitis or a persistent rhinitis for any severity. And you can see down below some of the common molecules that are used today. Some of the key features for the intranasal corticosteroids is that it has very low systemic bioavailability, so it oftentimes can even be used on patients who are pregnant. They can take several days to actually get up to their ideal usage, so you just have to let patients know that they may not get an immediate benefit for it. When congestion is a dominant symptom, these are definitely the go-to agents. If you're using this on children, it's best to be used in the morning. And that's the reason for this is that the natural cortisone levels are highest in the morning, so it'll get the least absorption at that time. All of the nasal steroid sprays are pregnancy category C. However, budesonide as an asthma inhaler is a category B medication. Side effects include headache and nosebleed as the most common one, as well as a bad taste in the mouth. And I find that these can be avoided if you just instruct the patient on how to use the steroid correctly. I have them tilt the head forward, I tell them nose to the toes, and to spray with the opposite hand. So on the left side, they use their right hand, and on the right side, they use their left hand. And if you look in the mirror, you'll see why, is that directs the nasal spray towards the lateral nasal wall and away from the septum, so they don't get these side effects as often. Now, systemic corticosteroids, these can have some important long-term effects. And I would just take a look at this list and just look them over. Very important, and this is why we try to really limit the number of times where we put our patients on a Medrol dose pack or a course of oral prednisone. And sometimes these effects don't even have to be seen after long-term usage. There are some side effects that can occur very quickly as well. So let's talk now about topical antihistamines. We have some ocular preparations, which are very useful for eye symptoms specifically, as well as nasal sprays such as azolastine and olopatadine. So intranasal antihistamines, they have a good anti-inflammatory effect. They have been found to be superior to oral antihistamines. However, they have not been found to be superior to intranasal steroids. They also have a very good effect for nasal congestion, and it works pretty quickly. So even in patients who have the common cold, if you're looking to reduce congestion and they perhaps can't use the oral decongestant medications, which we're going to talk about in just a short while, intranasal antihistamines are a very good option for them. I also find that the intranasal antihistamines are very good for my mixed rhinitis or my non-allergic rhinitis patients. Oral antihistamines, these are our H1 antagonists, and they come in a first and second generation group. They are excellent for reducing the symptoms of sneezing, itching, runny nose. They only have a mild effect on nasal congestion, so they really have to be combined with a decongestant or perhaps an intranasal antihistamine as well. But they can be considered first-line therapy in patients with allergies who have minimal nasal congestion. So the first generation oral antihistamines, they demonstrate competitive H1 receptor binding. They have a very rapid onset, but a short half-life in the serum. They do cross the blood-brain barrier, and this is what gives some of their untoward side effects. They can have anticholinergic effects, like blurred vision, urinary retention, xerostomia, and also thickening up of the mucus, which is something that many of our patients really don't want. And these are some of the generic and trade names for the first-generation antihistamines. So the second-generation antihistamines do not have the same anticholinergic effect that the first generation does, and they also don't cross the blood-brain barrier as well. These were introduced in the 1980s. Seldane was the first to the market. However, this was taken off the market due to cardiac toxicity. And the others that joined the market, Allegra, Claritin, Zyrtec, and then some derivatives of Claritin, for example. Clarinex was the most active metabolite. of loratadine. And then Xyzal was introduced, which is the L isomer of cetirizine. And interestingly enough, if you pronounce cetirizine backwards, you're going to get a word that sounds similar to Zyrtec. Many people think that the oral antihistamines are just benign medications, and you'll see a lot of patients who have come in on one of these agents and they've been told to stay on it for years and years. However, it's important to understand that the longer you use it, the more likely you're going to develop some of the anticholinergic effects. Also, the medications tend not to work very well when you use them consistently. And one of the most dreaded side effects is that you can gain a physical dependence to them. So if you give somebody without any problems Claritin for an entire year and then take it away, they're going to get sneezy, itchy, runny nose, and they're going to look just like your allergic patients. So your patients might be having symptoms because they've been on these medications too long. That's a bit counterintuitive, and many times patients will resist your recommendations to decrease the medication, but it can be very helpful to them. If you're weaning a patient off of long-term antihistamines, I would do it in stages, each plateau maybe 3 weeks or 4 weeks at a time, and after about 3 or 4 reductions in either the dose or the frequency of the medication, they can generally convert to an as-needed use of antihistamines. And I've also seen some patients who, particularly older patients, who have used antihistamines long-term and have developed arrhythmias because there are histamine receptors on the heart as well. So let's talk a little bit about the mast cell stabilizers. There was a lot of excitement for this class of medications when they first came out in the 1990s. However, some of that excitement has waned in the recent years. They're found to be very effective in preventing symptoms, so they have to be used really prior to being in the situation where you're going to develop symptoms, which can be difficult. They stabilize the mast cell membranes, but the dosing is very difficult. It has to be dosed several times per day, and it has been found to be less effective than the nasal steroids or antihistamines. Now, decongestants, this is a very common class of medications. They're available over the counter by and large, so many of our patients will come in having used these for a variety of reasons. These medications are really only good for nasal congestion. They are a one-trick pony, and you can see down below the different categories of the decongestants as well as the mechanism of their action and some examples. So let's look at the topical decongestants. These have a very rapid onset of action, and these work in a similar way that the oral decongestants work by constricting blood vessels inside the nose. They have a local potency which is even greater than seen with the systemic, but unfortunately they also have a greater risk of rebound potential. So that's why we try not to have our patients use these medications for longer than, say, 5 to 7 days in a row. And below you'll see some common examples of topical decongestants. So the systemic decongestants, they have a weaker effect on obstruction than the topical ones, but you also have a less chance of rebound effect. They can cause some side effects, particularly when used close to bed, such as insomnia or anxiety. Many patients will develop tremors or palpitations or increased blood pressure. So you have to use this with caution in patients with certain medical conditions and also patients with certain medical problems. And pseudoephedrine can be converted into methamphetamine, so that's why these medications they're over the counter, but they're behind the counter, so you have to give your ID and register before buying them. And these are some common generic and trade names for the decongestants that are available. So let's look for a moment at anticholinergic agents. I find that these agents are very helpful in my practice, particularly when the main symptom that patients are complaining of is watery rhinorrhea. This inhibits the parasympathetic function within the nasal mucosa, and it can be used for allergies as well as people with the common cold, as well as that sort of senile rhinitis, or patients who are on beta blockers and it's causing the side effect of rhinorrhea. It has a limited role as monotherapy in allergic rhinitis. Oftentimes it's used along with other agents. You can start it with a dose in the morning and then repeat it in 6 hours if needed. You have to be cautious because of its anticholinergic effect when you're using it in elderly patients or patients with narrow angle glaucoma or problems with urinary retention. Now let's focus a bit on the leukotriene receptor antagonists. This is a very exciting group of medications. Leukotrienes back in the day were called the slow-reacting substances of anaphylaxis. I think they have a much cooler name now. And this was found to come from the breakdown of arachidonic acid. So they're produced by multiple cells, which you see below, and there's different types as well. And you can see the effects of leukotrienes in the Whelan-Flare reaction, as well as bronchoconstriction and the attraction of other cells like neutrophils and eosinophils. So here we see a diagram of the formation of the leukotrienes from arachidonic acid. And here we see where the medications are going to interfere with that formation. So the leukotriene receptor antagonists have a comparable effect as the oral antihistamines when treating allergic symptoms. However, as monotherapy, they've been found to be less effective than intranasal corticosteroids. And combining the leukotriene receptor antagonist and the oral antihistamine, well, together they're more potent than either of them alone, but neither of them are more effective than intranasal corticosteroids. They have a very good safety effect profile, and they have been used for many years in patients with asthma, which was its first indication. Allergic rhinitis came second. Some of them, however, are associated with liver toxicity, and liver function must be monitored. And there's also been excitement for their use in nasal polyposis and aspirin triad patients. And here you see down below some of the common examples. One of the common ones we use in the United States is montelukast. Now, combination therapy has also been found to be effective compared to using either of these agents alone. Fluticasone propionate and azolastine, that has been shown to reduce total nasal symptom scores significantly over placebo or either active agent alone. It's reasonable to combine intranasal steroids along with nasal antihistamines in patients who are not responding to monotherapy. And intranasal steroids with oral antihistamines, they haven't really been found to have an advantage over the intranasal steroids. However, if the symptoms are persisting, they can be added on. You can also add a leukotriene receptor antagonist to intranasal steroids. Oral antihistamines and leukotriene receptor antagonists, as we mentioned before, together they're more effective than either of them alone, but the combination is not more effective than intranasal steroids. And so this is a diagram showing step therapy for allergic rhinitis. There's also a similar type of diagram for the management of asthmatic patients as well. And what it really shows is starting with the lowest step, with the lowest amount of medication that the patient needs in order to feel comfortable. So that could be an oral or an intranasal antihistamine, and then once symptoms become persistent, adding an intranasal steroid, and then beyond that, considering combination therapy or adding other agents on. And that's why it's very important also to follow patients very closely, because the rules change every season, and you might find that what works at one time of the year is not going to work at another time of the year. So you may have to step them up at certain times if the season has changed or is severe, or if they have other concomitant illnesses going on. And then there are some times of the year when you're going to be able to step them down in therapy. Now let's talk a little bit about monoclonal antibodies, which is something we've been seeing a lot in the literature and we've been hearing a lot about, particularly anti-IgE, anti-IL-4, and anti-IL-5. So Xolair, or omalizumab, is an anti-IgE. It selectively binds to human IgE. It binds to the Fc portion, so the constant portion of the antibody, and it prevents binding of that IgE to the surfaces of mast cells and basophils. So you can see in this diagram how it prevents the cross-linking of IgE and the binding of IgE to the mast cells, thus preventing the type 1 mediated hypersensitivity reaction. So this medication modulates the allergic inflammation by two mechanisms, by reducing the free IgE that's circulating and also decreasing the binding of IgE to its receptors. This is approved for patients who have moderate to severe or severe, poorly controlled allergic asthma. While it's not indicated just for allergic rhinitis or just for nasal polyps, in those patients who are taking this medication, the allergic symptoms are much better controlled, and it also is helpful for the control of nasal polyps as well. However, there are some downsides to this medication. It has a high cost. There have been some reports of anaphylaxis, and there's also a lack of oral or topical routes of administration. There's also a lot of research currently going on for monoclonal antibodies against IL-4 and IL-5. And while they haven't had the same success that Xolair has had, probably because of the redundancy of the pathways, there are still some ongoing studies with these molecules as well. Thank you for joining me today.